This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Steve Love along with Thomas Miller. Welcome. We know it's 4th of July weekend, but we got some serious things to talk about. Thomas, do you have your mask?
I have my mask and I have been wearing it, sir. Yes, sir.
Absolutely. You know, we are on a pivotal weekend. This 4th of July is going to determine in 14 days community spread. Did you know that?
Yes, sir. It's been in every local headline. And the other thing is, boy, we just turn around from this and the kids are back in school and then it's flu season.
Absolutely. We really have got to take this seriously because if we don't control the community spread, Thomas, we're going to be in a surge situation by the end of July.
What would that look like?
It would be where hospital capacity was really taxed. We were having to put in what we call emergency surge procedures, and it's going to be very taxing on one, the workforce, two, PPE, personal protective equipment, and then finally, bed capacity. It's going to be quite serious.
Anybody listening to KRLD this week, reading the headlines, watching television news, knows the headlines. We topped 8,000 for the first time of daily cases. We topped 500 for the first time in Dallas County. We've had stories of young people affected by this in the hospital and a couple of deaths of younger people. The 6 players on the FC Dallas soccer team testing positive. Steve, it looks to me like we're not having such a successful overall reopening game plan here. Is that how it's being interpreted in the healthcare community?
In the healthcare community, as we run our models, as we look at what we call the doubling rate, how quickly it doubles, that continues to come down, which tells me community spread continues. So, Thomas, we've got to get after this. We've got to bend this curve, or we're going to have a surge, which we had hoped never to have.
So, Steve, people are broadly going to restaurants, going to public gatherings without a mask. I mean, what are we going to do here? What's the solution?
You know, I don't know. I guess ultimately we may have to just mandate you have to wear a mask. And I know some people think it's my right not to wear a mask. But think about it like a seatbelt. You wear a seatbelt, and when you wear a mask, you're not only protecting the community, you're protecting the people you're interacting with.
From your personal perspective, do you think that the mask would solve the problem, or is there more to it than that?
Well, when I listen to the infectious disease physicians, they say the number one thing you can do is wear a mask and practice good physical distancing. If we could do those two things and get 100% of the people to do it, it would make a tremendous difference.
When you talk about this taxing the hospital system, could we be looking at what we saw in Italy and New York?
I certainly hope not, but it could come to that. It really could. And if nothing else, do it for the healthcare workers, because you are making them fatigued, exhausted, and you know what? They have families too.
Speaking of, how are the hospitals holding up right now? And I'm asking this from this context. I'm seeing a lot of my friends I think everybody's just kind of at the end of a trigger. It's like, seems like everybody's really tense right now. How are the hospital staff people holding up through this?
Yeah, you know, I want to answer the question, and I will, but then I want to put a caveat on it. You know, currently the hospitals still have capacity. You know, when you look at the number of ventilators, the beds we've got, the ICU beds. But what I don't want is the message to be, oh, the hospitals in North Texas have capacity. Let's go out and do what we want to do. That is not the message. The message is we have effectively managed our COVID-19 hospitalizations to preserve capacity, but we cannot continue. the rapid increase in hospitalizations that we've seen in the last 2 to 3 weeks. So we've got to do our part to curb this infection. With that said, Thomas, do we have the bed capacity? Yes. Do we have the PPE, personal protective equipment? Yes. But I worry more about our workforce. These folks are really heroes. They have been at this for over 4 months. They are constantly caring for the COVID-19 patients. They're getting fatigued. They're getting burnt out. So you can have all the capacity you want. You can have all the PPE you want. You've got to have a good, healthy workforce.
So from the latest statistics, how did the week wrap up? How close are we to a real problem?
Well, in looking at the models, I've said this, and I almost hesitate to say it. Currently, we have the capacity. But what we're looking at as far as the hospitalizations that have increased, when we look at the number of tests and what's coming back and how that's increased, we could in 14 to 18 days see a significant increase in our COVID-19 hospitalizations.
Government officials from the federal level, state level, and even local level 60, 90 days ago were very quick to go to a quarantine. Now they are not. What are your thoughts on that?
Thomas, if we do this the right way, if people wear masks, wash their hands, do physical distancing, we can gradually open the economy and get back to the new normal, but without having to do a complete shelter in place.
And of course, that's what all of us want, is to not have to affect our economic lives and our personal lives, and yet this healthcare threat is amongst us. So we have an interesting interview coming up. We have a pre-COVID and post-COVID interview with Winjie Miao from Texas Health Resources. Winjie was actually in our studios back in February, Steve, right before COVID hit. Right after we did this interview, we had to change our own direction. But now we're going to go back and talk about technology in healthcare.
Absolutely. And you couldn't find a better person than Winjie. And she's going to tell you a lot about not only how we used it, but how we're now using it and how we're going to use it in the future. Lessons learned from COVID-19.
So we're going to do a part 1 and part 2 in our next 2 segments with Winjie. Part 1 is when we talked to her earlier in the year before COVID hit. And then in the next segment, we're going to bring it current and get her back for another update on what has changed since COVID, which has been significant.
Yeah, virtual visits are now becoming a reality. Some people did virtual visits, physicians, other healthcare professionals with their patients, but now it's become a way of life, and that's a good thing. So I think as you look to the future, lessons learned from COVID-19, Winjie's going to fill us in on some of those great nuggets of information that we've learned from COVID-19.
Winjie Miao from Texas Health Resources, pre- and post-COVID, medical technology and improving the patient experience. Coming up next on the human side of healthcare.
This is the human side of healthcare on 1080 KRLD and the radio.com app, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
And welcome back. We're going to talk with Winjie Miao. She is the Chief Experience Officer and Senior Vice President at Texas Health Resources. Her world is a world of technology and data, 2 of the biggest drivers in healthcare today. We sat down with Winjie initially before COVID hit, and after it hit, we obviously had to change our focus of this show to cover COVID, but we knew we wanted to cycle back and talk to Winjie. So in this segment, we're going to talk to her in the pre-COVID mode, and then in the next segment, we're going to bring things current and find out some of the many things that have been learned since COVID. Here now, Steve Love with Winjie Miao talking first about the importance of technology in healthcare.
Well, when you think about how our lives are changing or have been changing, and how we experience life, especially with the technology revolution. How we bank is different, how we shop is different, how we go out to eat or not go out to eat now that we can get food delivery whenever we want, has changed. And healthcare is going through that same evolution. And so as we think about what consumers and patients and people in this community expect from us going forward, we are really thinking through what those expectations are, understanding how to best meet the needs of the community here in North Texas, and delivering the new products and services and capabilities that allow Texas Health to do that.
You bring up a good point. I saw a poll the other day, and just one part of the population, the millennials,
Yes.
83% said we don't want to go to a physician's office. We want an app on our phone, and we want to go to a mini clinic, whether it be at Walgreens or CVS or somewhere else, but they don't want healthcare delivered traditionally the way that most people have known it. So what kinds of teams are you leading as you innovate and make changes at Texas Health Resources?
Well, you hit on one of the big ones, definitely, as we look at being able to provide access to care 24/7 to people, truly meeting them where they are. The digital component and utilizing technology is a big piece. So the digital health team is one that we put together then with our new product development team, and they are both developing new products and services based on consumer research and market insights that we are gathering together. And once you have these insights and a new product or service, whether it's digital or still physical, we have a lot of products still that are physical products. We have to be able then to transform some existing businesses and be able to design and deploy those throughout Texas Health. So if you put those pieces together, that's really the team that it comprises the experience office. And the last piece of that is once you've created this new product and are able to deliver on it, then being able to tell the world about it. So you put all those components together, and that's the team that is under the Chief Experience Officer.
That makes a lot of sense, and we hear a lot about consumer-centric. But where do consumers really play into this?
I think that the health systems in this market, Texas Health and others, provide excellent quality care, and we've been delivering a great experience for a long, long time. Whether you're having a baby or you're coming into one of our emergency departments or coming into one of our physician clinics, you get a great experience both clinically and experientially. I think what we're learning is that when you're a patient, we deliver excellent care and an excellent experience. But as we go through our lives each and every day, sometimes we're patients and sometimes we're not. And even in those times we're not, we're looking for ways to support and improve our health. And that's really where the consumer part comes in. How do we think about the entire health journey? How do we think about each individual in their daily lives, wanting to improve their health, and how do we connect all of those things together, both when you are a patient and when you're not a patient, and provide you those products and services, and we meet you where you are. So a great example of that is a partnership that Texas Health has with a company called Dispatch Health. Dispatch Health is able to provide really urgent care and a little more than urgent care services, some acute care services at your home. And so you have the ability to call them up or through an app or through your physician's office, be able to say, this is what's going on with me, and we can send Dispatch Health to your place of work or to your home so that you can receive care without having to figure out if you're a mother of three. Gosh, I have one sick kid. Do I load my two healthy kids in the car and hope that they don't get sick when they're at the doctor's office or urgent care? Or we've also heard really amazing stories from our senior population. So some of them, aren't as mobile as we are. And so the ability to provide care where they are has really been a game changer.
We've talked to other people on this show, and everything you're saying just really rings true. people want to move treatment, if possible, to their home. They don't necessarily want to be in the traditional sense. Now, I realize if you're having a severe episode of illness, such as a cardiovascular problem, you've got to be in intensive care. But there are many people who now view themselves not as patients, but as consumers. And you've done a good job of talking about that. You know, Thomas and I even had a little, I wouldn't say disagreement. I kept referring to patients, and Thomas said, Steve, they are consumers. So do you want to elaborate any more on that?
I think that there are times when we are all patients, and there are times that we're consumers. And, you know, that patient-provider relationship is a very sacred one that is truly a healing ministry that we take very, very seriously. And we know that that is something that is entrusted to us. There are also times, though, when you're not a patient with us, when perhaps maybe you're just looking for some advice, or perhaps you're a family member supporting somebody who is a patient of ours. How do we best support you as a family member in that? During that time period, you're a consumer of healthcare, but you're not the patient. And to think of it only as the patient is a little bit narrow for Texas Health. And so we're really widening the aperture of how we think about health, how we think about patients and consumers, and how we think about ourselves as an organization.
You know, Winjie, I've known you for a number of years, and I know you have a strong biomedical background. So I'm going to put you on the spot. You know, as we talk about virtual doctor visits and ER apps and how we know the young people want things to change, as you look in your crystal ball, what does the future look like if we fast forward 10 or 15 years?
I think that you will see a lot of the things that you just described, a lot of care that we can provide via virtual means. I think that we will see a lot of computer-assisted, whether you call it artificial intelligence or machine learning, supporting our providers and caregivers in decision-making. And I specifically say supporting and not replacing, because there is an art and science to medicine, and there are a lot of companies out there that are able to do amazing things with machine learning, but it's still both the human and the computer together that gives the best result. And we've seen that whether it's Watson trying to beat a chess master at chess, or other examples. It's not the computer by itself that's the best, or the human by itself that's the best. It's when you put the computer with the human together, that's when they win each and every time.
To advise our listeners, what would be your general advice just to patients, consumers that are looking to experience the healthcare? And unfortunately, sometimes people don't plan to experience it. They don't wake up and go, oh, I'm going to the hospital today, unless it's an elective surgery. But do you have advice on nuggets of information to help people as they look at the delivery system today and how it may change?
I think the healthcare system is changing and is very complex. My one piece of advice would be find that trusted advisor, whether it is a family member or a physician, or perhaps it's a nurse in your family, and ask those questions, and don't be afraid to ask, and be able to articulate what it is you need. Oftentimes, especially when I was in the hospitals every day, I saw patients and families saying, well, I'm not sure, should I ask that? And they're already doing so much. Please ask, because we have the privilege to serve you, and that is what we want to do. And if you can ask for that information and tell us what we need to do differently or better to serve you, that is the best way that we can do that. I always say that feedback is a gift. And so I invite all of your listeners, if there is something that we can do better, please reach out and tell us.
And Winjie truly means that. The DFW hospitals all over the Metroplex are indeed here to serve. And you've been hearing that theme all this year here on the human side of healthcare. Now, when we come back, we're going to talk to Winjie about the latest lessons after COVID-19. What have we learned from all of this, and how are we applying it? That's next on the human side of healthcare.
The DFW Hospital Council, along with our over 90 member hospitals in North Texas, are proud to bring you the human side of healthcare with Council President and CEO Stephen Love and co-host Thomas Miller.
And we're continuing our discussion with Winjie Miao. She's the Chief Experience Officer and a Senior Executive Vice President with Texas Health Resources. And Winjie's talked to us a lot about the technology revolution. So let me ask you, Winjie, since COVID-19 has come to town, what are 2 or 3 things from a technology point of view that you've gleaned from some of the things when we've interacted with patients, the consumers, the physicians? Anything you can share with us, some nuggets of wisdom related to technology?
Yeah, COVID has certainly upended all of our lives and caused us to go about our lives a little differently, and healthcare obviously is no exception to that. When I think about, when looking back, what the most lasting trends for COVID will be to the health system, I really point to a couple things. The first is the accelerated adoption of telemedicine and televisits. Whether that's a virtual visit with your doctor or in our hospitals, we have also implemented virtual rounding to limit the exposure that our staff might have to COVID positive patients. The idea that I can have an interaction and that we don't have to physically be in the same room and I can get the same level of care is astounding. Once COVID hit, we went from, a handful of virtual visits a day in our Texas Health Physician Group practices to well over 5,000. And we know that our patients have really enjoyed having that ability. On the hospital side, we've employed both virtual rounding for our caregivers, as well as using virtual technology to connect patients with their families. So on the virtual rounding side, what we've been able to do is allow caregivers to interact with patients, mostly on COVID positive patients, and continue to have that interaction, but really minimize risk of spread of disease. We have that in the emergency department as well as on the inpatient units. And then really the ability to have family members still connect with our patients. As you know, we've had to limit the number of visitors in our facilities, and utilizing technology, whether it's simply FaceTime or other video conferencing modalities, so that loved ones can continue to stay connected and ensure that their family members are communicated with is really important. So that's another way that we've used virtual rounding, if you will. So virtual rounding both for caregivers, but also allowing family members and loved ones to connect with patients in the hospital. I think another technology that we are also really employing is really something that most patients won't see, but is essential in the way that we are responding to COVID, and that is using our real-time data and analytics and the predictive modeling and some of the machine learning capabilities that we have, and being able to look at how we've responded to these patients, the amount of, for example, supplies and PPE that we utilize, the amount of staffing that's required for these patients, the bed capacity that we have, and being able to look at our historical trends and then being able to predict that forward so that we can ensure that we have the right supplies, equipment, and staffing across all of our hospitals to be able to take care of patients. And most importantly, to be able to move those assets all across our different hospitals and support them as they have needs. So that's a second area where we've really utilized technology in perhaps not as much of a public-facing way, but is essential to how we've been able to successfully manage through this pandemic.
So, Winjie, you bring up an excellent point on the real-time data and analytics. And to our listeners out there, let me explain to you a little bit from my perspective of how important this has been. In many cases, you do research, you do development related to vaccines and the treatment of disease, And it takes years. We haven't had years. COVID-19 came to us about 4 months ago, and it has been amazing. The real-time data right here in North Texas that our clinicians and our doctors have looked at, things they've learned from New York and Italy, and how they've applied that. And Winjie, I can only imagine the data and analytics that come out of COVID-19 patients that you've treated in the last 60 to 90 days and how you and your team are learning how to improve the treatment you're giving now. That is a great point you made.
Yeah, thank you, Steve, for that. Yes, you look at the way that we treat COVID patients and what we've learned and over time. And just recently, actually, a group of our clinicians at Texas Health Dallas authored a journal article on their experiences with COVID patients with specific treatments. So not only are we ingesting a lot of the lessons learned from Italy, from New York, and other places, we are also contributing to the literature and really supporting all of us, the entire world, as we learn how to treat this very much emerging disease.
Kind of pivoting back to look at some of the technology, even not treating COVID-19 directly. I've talked to a lot of clinicians that have used the technology, the telehealth, the virtual visits to treat depression, anxiety, cardiovascular problems. It's been amazing how this information technology revolution has crossed all the patient care, not just COVID-19.
Yeah, absolutely. When we talk to our patients, they really, COVID or not, they really appreciate the convenience. They appreciate the privacy, especially sometimes when you're talking about mental health issues. You don't want to walk into an office that everybody sees that is a mental health provider's office. And unfortunately, there's still a stigma in the U.S. around mental health. And so virtual visits allow that privacy, they allow that convenience. And we have found that our patients have really adopted virtual visits, both COVID and non-COVID patients. And I'll provide you with an anecdote of a patient comment that we received, because we're surveying all of our patients after they've completed a visit. And overall, our patients are very satisfied. And one of them wrote us and said, this is exactly what I've been wanting for a long time. And don't you dare pretty much take this away after COVID. You need to keep doing it. And we definitely will. It's a technology we were standing up prior to COVID. Clearly, COVID accelerated the stand-up of our virtual visits, and we will continue to offer virtual visits for a long time to come.
Last week on the show, Thomas and I had the privilege of interviewing one of your patient navigators, Erin Prendergast, and she does work with cancer patients and helps reassure them and navigate them on their journey of treatment. And she even expanded on how she's having to do virtual interaction to help patients navigate. And it's so much better than just doing a phone call or sending an email. So, there's just so many potential possibilities on how virtual can help us treat patients.
Well, we've talked about virtual visits in terms of face-to-face, video visits, but we've also launched some technology that allows you to chat with a physician anytime, 24/7. And so if you're a THPG patient, or if you've been discharged from one of our THR hospitals from the emergency department in the past 7 days, you have access to an app that allows you to chat with a emergency department provider 24/7 with any questions that you may have, whether that's questions about your discharge, or whether it's, I don't feel like I'm getting any better, or I couldn't quite remember what the physician told me. So it's not just the virtual visit, but it's also chat functionality and other technologies that we're putting in place to support all aspects of patient care that I think are really exciting, that have really accelerated us 3 to 5 years at least in terms of adoption, and we're excited to continue to provide more of these offerings to the community.
So let me go back and ask you another question, and then I'm going to let Thomas ask some because he always has such great questions. But let's go back to the virtual rounding. And for our listeners out there who may not quite grasp what rounding is, but it's when the team comes to deal with a patient. And pre-COVID-19, the team and the rounding would occur within the patient's room. But to help limit exposure to COVID-19, you started doing virtual rounding. Did the team members all sign on at the same time through the virtual rounding to interact with the patient? So all the huddles, if you will, took place virtually? Or can you expand on that a little bit?
Sure. The way our virtual rounding works is the patient is given a device, and then the care team member, so the clinician, the nurse, the doctor, the RT, they have a device, and they can interact with that patient one-on-one without having to go into the room each and every time. Now, obviously, if the patient has a need that necessitates a clinician going into the room to have a conversation or to do a procedure or adjust a piece of equipment, they will do that. But it is a good way to minimize risk as well as meet patients' needs in a really safe way.
COVID-19 has changed all of our lives and certainly has changed healthcare, as you've just heard. Be sure to catch our podcast, The Human Side of Healthcare, on all of the major podcast players. When we come back, we're going over to the Methodist health system to talk about the ongoing opioid crisis. It, too, has not gone away. That's next on The Human Side of Healthcare.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environments. This is The Human Side of Healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome back to The Human Side of Healthcare. You know, Thomas, one of the things, unfortunately, from COVID-19, there's been an increase in opioid misuse. Did you know that?
That does not surprise me in the least.
Yeah, from what I understand, especially from the behavioral health specialists, that's something that, unfortunately, the misuse has continued. So we thought it would be good in this fourth segment to bring in Dr. Brian Jones, who's from Methodist Health System, and Shannon Huggins, also from Methodist Health System. So we can kind of pick their brains and ask them about opioids and opioids misuse.
And starting with the first question of how is the Methodist Health System addressing the opioid crisis?
Thanks for the question. We recognize that the opioid crisis is a huge problem in our community. In fact, I think the numbers that came out were that nationwide last year, 61,000 people died of opioid-related causes. To address that, we started off by looking at what we were doing internally already. And each of our campuses has an opioid safety committee that looks at the opioid use in the hospital setting and how are we monitoring that, how are we developing best practices around opioid use in the hospital. And we decided we needed a larger organization that would look at the opioid use and opioid crisis across our system and across our community. So we started in 2017 the Methodist Opioid Safety Initiative, which takes the work of those opioid safety committees and elevates that to a system level and looks at it, like I said, across the community.
You know, Dr. Jones, you bring up an excellent point. You know, to our listeners, there are legitimate uses for opioids in the appropriate setting, but many people may not know that hospitals many times receive report cards. And I'm not going to get into all the details of running a hospital, but we had something called HCAP, and I'm not going to get into what that is, but it dealt with, was the patient in a painful way or were they pain-free? So there was a real push to look at patient satisfaction related to it. And what Dr. Jones is describing and what hospitals are now really focused on is there is going to be some pain associated with some procedures, such as surgery. Now, we're going to try to minimize that, but we're going to try to do it without always using opioids. So I want to thank you for explaining that so our listeners can know there's going to be a little bit of pain associated with some procedures. Now, part of this deals also with drug take-back. Do you want to explain that program and how it works?
Certainly, but I'd like to speak to what you said just a moment ago about the pain expectations in the hospital. You're absolutely right that we want our patients to have a very positive experience when they're in the hospitals. And it's sometimes with procedures that we do, the surgeries we do, pain is unavoidable. And it's important that we set the expectations for the patient. But it's also very important that as we think about the opioid crisis, we also continue to think about effectively managing patients' pain. So we can't focus one-sided on not using opioids where they're appropriate. So we try to make sure that we use opioids where they're appropriate. The other thing that we do, especially in the hospital setting, is what we call multimodal pain management. So we're using all the different forms of pain treatment and pain amelioration that we can. That includes steroidal anti-inflammatory medications such as ibuprofen, Advil, Tylenol. It does include opioids as well, but also includes lighting, aromatherapy, comfort animals, comfortable music, and comfortable surroundings. Those things are all important. And then on top of that, we monitor how often we have adverse events related to opioids and try to learn from any adverse event related to an opioid where we have to use an opioid reversal agent, things like that. That's the strong work that the opioid safety committees are doing.
Thank you for clarifying that and explaining to the listeners that there are alternatives that you're trying to do. And going back, the drug take-back program, how does that work?
Thank you. It's very important for us to try to remove opioids from our community. We have a very low opioid prescribing rate at the Methodist Health System right now, but not all the opioids in our community are coming from our providers. And so the DEA sponsors a twice yearly actual drug take-back day that's a national event, and we began participating in that in early 2018. The first one was in April 2018. There was again in October 2018. And we've been doing it at two campuses, at our Dallas and our Charlton campus. And between those two campuses and in the last event, just the last event, we took back 700 pounds of medication. Not all of those are opioids, but a significant portion is, and it's free to the public. We encourage all of our communities around those campuses to bring in their medications and dispose of them properly. And we also have drug take-back containers at all of our pharmacies at each campus.
And did you say 700 pounds?
Yes.
Wow.
Why would somebody not, A, throw their opioids in the trash, B, put them down the sink or the disposal, and C, put them in the toilet?
Well, we certainly would discourage that. I'm certain that it happens a lot, and that has historically been one of the ways that people do dispose of medications, or they go in the trash, in which case they end up in our landfills or they end up in our water. And that's a real risk of contaminating our water supply, the groundwater, that sort of thing. We take those medications, they go back to the DEA, and they're all disposed of in a safe manner.
You know, one of the tools in dealing with opioids and the opioid crisis is education. And I look at some of the community outreach that I know you do. Are you educating churches, schools, community?
Well, that education has been occurring. We are standing up our education platform this year. Last year, we focused on looking at what the opioid crisis looked like from a Methodist perspective and how we could engage people in the drug take-back. This year, we are developing our education program, and that will be with the churches. We've identified some target churches we want to address, and certainly with schools as well. A lot of schools have their own programs, so we'll try to supplement them when we can.
Methodist has a very deep connection into the faith community, particularly in our service area. And so we've been working with that avenue to really start feeling out what areas, what church congregations could we start doing this education with and incorporating that in our whole faith care services.
You know, I know it's early on in the program, and some of it you're still developing, but I know you've worked to educate people about opioids. Are there any metrics, or do you feel you are making progress, or is it just too early to tell?
So yes, we do have a metric. The two metrics we primarily look at are the number of morphine milliequivalents per day that a prescription is written for. The Methodist physicians are well below the state average on that metric. And then the other metric we look at is the number of prescriptions that are written for 7 days or less. In fact, the DEA is requiring this year that all prescriptions for acute pain medicines are written for 7 days or less. And we're seeing that being advocated at the pharmacy level and at the employer insurance payer level as well.
So let me ask you this, to our listeners. If they suspect someone in their family or a friend potentially is using opioids and misusing them, obviously, what's your advice?
Well, the first thing they should probably do is talk with the person's physician, talk with their doctor, let them know that there's a concern, and hopefully they can find a way to do that that's respectful of the person, that their loved one. And they, of course, need to involve that person in this conversation, in this care. Your primary care provider is a great place to start. They're not unfamiliar with these problems. They see it happening, and oftentimes they have some visibility onto how that can occur and how it might have occurred for that person.
I have a 20-year-old son, but last year he cut his hand with a box knife and had to go to the emergency room and have several stitches. But he came home with an opioid prescription. And so before he ever took the first one, we started having a conversation about, do you really need, how bad does your hand really hurt to have to take that? And I wasn't being a mean mom. I was just saying, do you really even need to start down this road of having it? And so when we started talking about it, he said, I don't really need, I'll take an aspirin, I'll take ibuprofen, because, so we didn't even have to start on the use of it. So I think education's a big piece of just, why am I taking this? Why did I get it? What do other people have it? Why is the doctor prescribing? And just being clear with that so they know what the path is that they're going down.
We explore so much more on this topic on our podcast, The Human Side of Healthcare, including what might happen if you really needed opioids for post-surgery or multiple fractures or something like that. How are they handling that now? That's on our podcast. Happy rest of the 4th. Stay safe, wear your mask, and we'll see you next week on The Human Side of Healthcare.